Welcome back to the Humble Healer podcast. And today we will be talking about the opioid use disorder. And the previous episode, I talked about the rise of the uniquely American opioid epidemics and how it happened, and also the outpatient treatment for opioid use disorder. And today we'll talk more about medications that we use to treat opioid use disorder. So does opioid addiction treatment work? It can. The success of therapy for substance use disorder varies by patient and by severity of the disorder. Coexisting problems such as excessive alcohol use or underlying mental illness can complicate the recovery process. Research shows that there is a higher rate of substance use disorder among patients with diagnoses such as depression and those who use their other substances such as alcohol. For those who joining for the first time, I want to thank you for joining me, and I hope you find the podcast valuable. And please hit the like button and subscribe to the channel and share with friends and family. And this is Dr. Quang Lei. I'm a board-certified family physician. So a person may need a treatment approach that addresses both mental health and substance use disorder if both conditions are occurring together. The person's environment and access to supportive family members and friends can also play important roles. Some patients will need to repeat therapy and may relapse many times before achieving long-term success. Practitioners may try different approaches for patients who continually relapse. It takes several tries a lot of times for us to succeed in helping patients get to the point of complete abstinence opiates. It takes patience, kindness, and compassion to help get the patients through this. There is a common dual diagnosis that exists in any substance use disorder treatment, and there are patients that have completely no mental health history, but after a long struggle with opioid use disorder, they started having depression and anxiety associated with the opioid use disorder because opiates can cause massive withdrawal and lead to a lot of anxiety and depression. So, and also in patients with history of depression and anxiety, they also at high risk for opioid use disorders. So there's a very close interconnection between mental health disorders and opioid use disorders. And the success in helping patients do better with one disease depends heavily on the success of treating the other coexisting illness. Also, we talk about family structures. If a patient is trying to recover from substance use disorder, but is sharing an apartment or rooms with a roommate or a partner or wife or husband that are actively using, that will make it very difficult to get better, since there will be substance that the other person is using in the house or apartment. So that makes it more difficult. So having support from family and the community around them is very crucial in recovery for these patients. Important community support such as NA or Narcotic Anonymous, which is based on the same framework as Alcoholic Anonymous, and also important continuity of care with primary care providers. We also add stability to treatment of opioid use disorder. For patients with opioid use disorder, running out of opioids and developing withdrawal is perceived as life-threatening issue, similar to how we would perceive running out of water. People dependent on opioid would tell you they would rather die than go through opioid withdrawal, and they mean it. Many of those whose medical supply of opioids were taken away turn to street opioids and then needles. This is because heroin is a lot cheaper than oxycodone, as we talked about in the previous episode also. And when these happen, there is no longer any care about self-respect, job. They would steal money from their family, friends, and whatnot. And because this is just a terrible feeling. So make sure that you get these patients to get to detox centers to get them started with the treatment. And you may also save their lives. For the opioid prescribers, opioid addiction is the most lethal disease that comes through our doors. Approximately 1 in 10 patients with non-fatal overdoses are dead in 1 year. And this is rate of death that dwarfs disease. We have completely rebuilt the emergency department to prioritize such as stroke, myocardial infarction, or heart attack and sepsis. Like patients with these conditions, opioid use disorder patients are generally otherwise healthy Young people who, if properly managed, will go on to live healthy, productive life for decades to come. So great investment to help these individuals, as I've taken care of several of these patients and seen that how they can help bring their family together and allow the community and the family around them also to do better when the patient is successful overcoming opioid use disorder and can get a job and contributing to their family and society. While we have turned the corner on prescribing and the number of new cases of addicting is falling, overdose deaths are rising because American heroin had been contaminated in many regions, replaced by fentanyl and its derivatives. Also, there's um, strong acting and long-acting benzodiazepine called methylxanthine that has been added to prolong the effect of fentanyl, and this is also increasing the rate of overdose among users, and it leads to also a lot of complications and very horrifying skin disorders in rehab centers for patients using methylxanthine, and can lead to necrosis of the skin of these patients. Most of us learn not very much about addiction in training. The treatment of opioid addiction in medicine for a lot of especially the older physician, was a piece of paper with some phone number and a quick discharge. This is inadequate and stigma-driven approach to those with addiction. Until recently, most of us did not know better and lacked the appropriate tools to help. And this has changed in September 2018. We talked about how to unlearn the untruth that we were taught and change our prescribing practices. We also discussed a paradigm shift in how we think about opioid and addiction in emergency medicine and acute care medicine in general. We were trained to get the pain score to zero by liberally using opioids. Before that, we were told that this was safe and appropriate because addiction does not develop when you use opioid to treat pain. And we believe that despite thousands of years of evidence to the contrary, because of an astonishingly successful campaign of marketing and deceit by industry. Also because we were insufficiently skeptical of what we were told. We overprescribed medication and turned millions of Americans into daily opioid users. When we realized that we had done, we applied the brakes and told these dependent patients that opioids were bad for their health and that we would not prescribe more opioids. So we went complete opposite. Majority of these patients present in the acute care setting. These patients do not present to the addiction clinic after overdose, pneumonia, or cellulitis, or arrest. Many physicians are reluctant to expand the scope of their practice to include the treatment of opioid addiction. And that's unfortunate because this has impact just as much as treating a heart attack or pneumonia or any other serious illnesses. Overall approach to opioid use disorders recommended by experts in treating opioid use disorders in the emergency care setting or acute care setting. The 3 Ps: prevent, protect, and treat. Prevention means that preventing those who do not have opioid use disorder from developing it. Most people with opioid use disorder were first exposed to opioids from prescription, either their own prescription or from someone else's. The easiest way to reduce new cases of opioid addiction is to prescribe opioids to fewer patients with acute pain. Keep opioid native patient opioid native. I always, when patient had pain, saw a patient with fracture yesterday, and I did ask specifically, do you need medication other than Tylenol and Advil? And most of them will say, that's enough for them. But some will say, I took those and I still could not sleep last night. And that's when I will ask next is, do you have any issue with opioid use? And if they said no, they rarely use it or have no issues, then I will prescribe that. And you can do morphine immediate release, Vicodin, oxycodone, or hydrocodone. But I do not prescribe every 6 hours or every 4 hours or even every 8 hours. I do not prescribe more than twice a day dosing for these patients. And if you do prescribe every 4 hours and they take it every 4 hours, in 3 days, they will develop withdrawal. Just 3 days. And I try to give them something like celecoxib or another NSAID to help so they can alternate the treatment, or sometimes Tylenol, 1,000 milligrams. So, and I generally give them about 8 to 10, depending on the severity of the pain. Studies have shown that is most of the time is more than enough. We know who is at high risk to develop opioid misuse from a prescription: people with existing use disorders, including tobacco and alcohol, psychiatric disease, socially disadvantaged, patients under 25 and those with chronic pain. We do not have good tool to tell us who is at low risk. The right approach is to do an explicit calculation of the likelihood of benefit and harm for that individual patient. It is often used to do this in a collaboration with the patient in a shared decision making that frames our obligation to manage pain along with potential for pain medications to cause harm. Shared decision making is great, and that's why we should openly ask the patients whether, and a lot of them will say that they don't want anything to do with the opiates. And so they probably have family members which also have history of opioid use disorder or they themselves. Most patients will do well without prescription for opiates, but not all. There are some patients discharged after severe acute pain where the benefits of opioids might outweigh the harm. In patients that are discharged with opioids, the most important way you can reduce the likelihood of long-term use is to prescribe a small number of pills that we talked about. Also, another thing that can cause significant discomfort and morbidity is constipation. Giving patients with opioids or OxyContin or oxycodone can cause significant constipation. And I have had to treat a patient after surgery. He was given oxycodone and he ended up developing fecal impaction, severe discomfort, and could not poop because there is a mechanical blockage due to a large ball of stool forming in his anus, blocking the passage. It's very uncomfortable. So I make the habit of giving opioid prescription to patients with SANA. And for patients listening to this, I would recommend that you take any form of opioid medication with a laxative like SANA, which is very mild. How do you know you overtake SANA? You may have some loose stool, then you can ease up a little bit. But take it. Don't wait till you get constipated and then take oxycodone and then take constipation medicine. You may be behind the eight balls, like that gentleman that I treated and several others. For those that get the treatment with oxycodone, it may be best to reduce the prescribing of euphoric opiates such as oxycodone and hydrocodone. And morphine's immediate release is not as euphoric and can be given at dose of 5 milligram to 15 milligram, and it will be less addictive for patients. Also, providers have access to intravenous opioid in the acute care setting, and the patient in acute pain like kidney stone, which can be extremely uncomfortable, or fracture, or severe abdominal pain. And if the opioids are not contraindicated, it's acceptable to treat patients with intravenous opioid and can monitor them. It's perfectly safe. But I also make the habit of giving something like morphine with Zofran, a nausea medicine before that, since a lot of patients do have nausea and sometimes vomiting associated with taking morphine. And when it comes to opioid prescribing, none of this applied to the end of life terminal pain, where opioid harms are of much less concern. The second one is protection, is a harm reduction in patients with an existing opioid use disorder. This reduces the negative consequences associated with opioid misuse with the goal of encouraging health by meeting patients where they are and providing skills or resources necessary to improve well-being and minimize morbidity. This is the same way that we improve the lives of diabetic patients who continue to be overweight or non-compliant with their medications. We have a variety of tools to improve the lives of people with opioid addiction who continue to use street drugs. Remember that giving them opioid replacement therapy doesn't mean that you increase the chance of them having an overdose, but because these medications are safer than the alternatives with these street drugs that they are using. Just like giving them clean needles and syringe doesn't increase the risk, as studies have shown many times, of overdose, but it may reduce the risk of hepatitis C in these patients. So take-home naloxone is a life-saving product that should be offered to every patient and their companion at risk for overdose. This is ideally dispensed in the emergency department and can also be gotten over the counter. Many programs that can help provide Narcan for family and patients. And who's at risk for overdose? A patient presenting after non-fatal overdose. Patients who buy opioids on the street, also patients on high dose of prescribed opioids, or those who use prescribed opioid along with sedatives. You can prevent all sort of terrible harm due to injection by talking about safe use practices. Do you inject with other people around? Do you do a smaller tester shot to make sure a new batch isn't too strong? Or these very high risk habits that you can talk to them about. Providing clean needles, again, or referring to a needle exchange does not make your patient more likely to use. Offer screening for pregnancy, HIV, hepatitis C, as well as post-exposure, pre-exposure prophylaxis when relevant. Talk about food and housing insecurity, discussing co-occurring medical, psychiatric, and social problems that are often unrecognized and untreated. The treatment of opiate use disorders of interest is buprenorphine. This is partial agonist at the mu receptor. This means it causes less euphoria than full agonist, and there is a ceiling effect to its toxicity, which is another replacement therapy for opioid use disorder. Also, buprenorphine has a higher affinity for the mu receptor than almost every other opioid. So if a patient is therapeutic on buprenorphine, they are relatively protected from overdose on full agonists like heroin. If these patients take buprenorphine and then they have some cravings still, and there's some heroin nearby, they use it, the buprenorphine already binding to the mu receptors in their brain, making them less likely to have overdose with heroin, since heroin has less affinity to this receptor than buprenorphine. Now, on the other hand, if an opioid-dependent patient had full agonist like heroin in their system, and you give them buprenorphine, it will push the full agonist off the receptors, and the patient will experience buprenorphine precipitated withdrawal. If an opioid-dependent person is not in withdrawal, buprenorphine can cause withdrawal, and buprenorphine may be combined with naloxone as a deterrent to abuse. High-risk patients, such as adolescent or pregnant women, will also benefit from using buprenorphine. And also, it is an excellent treatment for opioid withdrawal and will quickly abolish withdrawal symptoms. If an opioid-dependent person is not in withdrawal, buprenorphine can cause withdrawal. So, sublingual buprenorphine is often combined with naloxone. And the most popular trade name of this combination product is Suboxone, and now available as a generic. The purpose of the naloxone is only to deter abuse by injection, but serves no other function. Buprenorphine and buprenorphine naloxone are interchangeable. Buprenorphine is the first line and the best treatment for opioid use disorder. It is very effective. Opioid use disorder patients who are successfully transitioned to the buprenorphine maintenance are able to reclaim their health and lives, as they are no longer spending all of their time and energy and money trying to acquire more opioids to prevent withdrawal. They are no longer injecting themselves with street drugs of uncertain identity using needles of uncertain sterility. Methadone is also an effective treatment for opioid use disorder, but can only be administered in specially designated clinics in the U.S. As a full agonist, methadone is far more dangerous and prone to abuse than buprenorphine. Many experts assert that methadone should be thought of as a second-line treatment for patients who fail or cannot be managed with buprenorphine. Abstinence does not work and should not be recommended for patients, even though they may have requested. The vast majority of patients who attempt abstinence-based treatment will relapse. Relapse in the fentanyl area is very dangerous. If a patient say that they do not want buprenorphine because they want to be clean, explain that it is similar to a diabetic not wanting insulin. Our goal is when we encounter an opioid use disorder patient who is not in treatment program is to move them to recovery with buprenorphine. This means administering buprenorphine in the emergency department or urgent care or acute care setting, prescribing buprenorphine, and referring to outpatient comprehensive medication-based addiction care. Some patients who are in withdrawal will decline buprenorphine. They may have misconception that you can correct, such as the notion that buprenorphine use replaces one addiction with another. Remember that buprenorphine helps opioid use disorder like insulin for diabetes. Some are not ready for recovery, want to keep using street drugs and know that they will no longer be able to do so if they are therapeutic with buprenorphine. So this is where we work with them to try to practice the risk reduction approach to help them. This can still help reduce risk of overdose. There's also injection called withdrawal that we use is naloxone, and it's a once a month treatment, and it's effective in more stable patients in long-term opioid use disorder treatment. The opioids, when you take that while you're on withdrawal or naloxone treatment, naltrexone, withdrawal is naltrexone, and when you use that long-term for patients, the patient use opioid, they will not have the same euphoric effect. And then another treatment now that's available is the injection with buprenorphine long-term. So instead of having to take that every day, now they can get a monthly injection. so that they do not have to worry about taking the pill every day, and reduce the cravings significantly. Once they wake up in the morning, you don't have to be without medication. You don't have to take the medication right away. There are also medication that we use to help reduce withdrawal, such as clonidine, hydroxyzine, gabapentin, and sometimes even use some long-acting benzodiazepines, which reduce effects of overdose to help manage withdrawal symptoms based on the risk of overdose for these patients. So I hope that you find this podcast helpful in terms of the medication and how they are used from a provider perspective. And hopefully you will learn that as a patient, what to expect when encountering treatment with opioid replacement therapy for family members and friends. And thank you for tuning in.